the way up to 2016, how opioid overdose mortalities amongst youth have changed. And you can see that between this 17-year period, about 9,000 children and adolescents died from opioid overdose. And over this period, a threefold increase, a 300% increase in mortality rate. And if you really look at mortality rates related to synthetic opioids, right, our illicit fentanyls, which is what we're seeing in ages 15 to 19, you can see this staggering, almost a 3,000% increase that we've seen. And this graph really breaks it down by the substance. So this one is looking at prescription opioids, and you can see it starts going up right around right turn of the century, peaks around 2008, similar to adults, and then kind of starts going down. This one's looking at heroin, right? Just as the prescription opioids start going down, overdose mortalities related to heroin start going up. Again, much like we saw in adults. And then here, we've got the synthetic opioids, and you can see they were sort of there, they're there. And then right around 2013, what do you see? This dramatic increase, right? This 3,000% increase or whatever, really coming into play. In the last 7 years or so. This only goes up to 2016, but of course we've seen ongoing increase in mortalities related to synthetic opioids, namely illicit fentanyl analogs. So that's really what we're looking at. This one is showing this graph here that, again, this is all focusing on adolescents, right? That between 2000 and 2020, mortalities related to opioids alone have gone up, and mortalities related to opioids and also opioids for other substances have also gone up. We saw this little dip, around, in this period, but we'll see long term, right, how that pans out. Kind of trying to just highlight some of the more pertinent points in some of these graphs. And here again, you can see it says youth mortalities, adolescent overdose deaths between 2010, very recent data going all the way up to 2021. And you can see once again this dramatic rise, right, in illicit fentanyls and synthetics that's really driving this mortality increase. That's the biggest increase we've seen. And this slide, I think, should give us pause, kind of looking at, opioid overdose mortality by adolescents by race and ethnicity. Some of these trends emerge where you can see this, and again, it's very pertinent, right, to us here in New Mexico and many parts of the country, where the kind of this most dramatic increase we've seen in adolescent overdose mortality has been in American Indian or Alaska Native youth, and followed only by increase in Latinx identified youth. So I think when we really talk about, our prevention efforts, treatments, impacting youth equally, or are there disparities emerging? This is really something to think about. And I know even today in our audience, we have several folks who are working with American Indian, Alaska Native youth. So really something that deserves a lot more attention, thought, and intervention to improve these outcomes. This is sort of looking at New Mexico, prescription opioid misuse in high school students, where you can see in 2017, just about 7% of New Mexico high school students reported using prescription opioids in a non-prescribed manner. And this tracks it all the way up to 2019, where you can see about, 3% of New Mexico high schoolers, 9th through 12th graders, reporting use of heroin, right? So, which is higher kind of than the national average, a little bit higher than the national average. The data is still emerging. I think this is still pretty new, but we can see this was an interesting paper that was published in 2022, and all the references are in the back, showing that, interestingly, during the COVID pandemic, fewer teens initiated substance use, including opioid use, probably because of the isolation, right? They weren't around their friends, they weren't around their social groups, and the access was limited. This paper appropriately points out that it doesn't mean that all was healthy, right? There are adverse effects related to the isolation, the lack of social contact, things like anxiety, depression, but also things like financial hardship, trauma, abuse, all of course impacted youth mental health. But interestingly, this paper pointed out that there was less of an initiation onto substance use, at least during the height of the pandemic. So I thought I would include that. So why should we care, right? So with that little bit of background epidemiologic data, the next piece, of course, is why should we care? So this data is old, as you can see, from 2008, that still uses DSM-4 criteria, right? We've moved on towards DSM-5, of course, at this point. But what this essentially shows is that as opposed to youth, adolescents who simply try substances, kind of use them recreationally, but don't meet criteria for an opioid use disorder, right? Youth that do meet criteria for opioid use disorder. So in other words, their use is more severe as opposed to just experimental, as opposed to just using it recreationally. What you find is that there are just more challenges that are faced by these youth. They tend to be more likely to be non-students, so they're no longer involved in academics. They're no longer in school. They tend to have need more services for psychological problems, worse health, physical health, more likely to have a history of depression, right, including these depressive episodes, sell illicit drugs, and also use multiple drugs in the past year. So both their substance use disorders tend to be more severe. They tend to have other co-occurring psychiatric illnesses, and they also tend to be faced by more sort of psychosocial challenges, social determinants of health, as this points out, beyond just the mortalities that we early on focused on. These youth who have a substance use disorder, who have an opioid use disorder specifically, again, tend to use other substances, have more mental health concerns, more likely to have trauma or PTSD, challenges with education and employment, right? This is sort of really oversimplifying it. But what this is showing is that, right, adolescent brain is still developing. This is something we often talk about. So there's, adolescents are more likely, right, to impulsively start using substances, and the substance use is more likely to become a learned behavior, more likely to get ingrained within this developing brain, as opposed to someone who experiments with a substance in an adult. That's really what this study is really focusing on. And long-term outcomes tend to worsen. So I think that's why we often like to point out, right, in the world of addiction medicine, addiction psychiatry, that probably one of the most impactful times to intervene in someone who's using substances is during that adolescent period. Because if you can intervene successfully and effectively at that time, you can hopefully improve the long-term trajectory. And without that intervention, the long-term outcomes can be quite bad. So that's why this is sort of an opportunity. This is, if we see someone's using substances, we really want to intervene. And we know that effective treatments exist, right? This is something we talk about a lot in this ECHO series. And yet, treatment for opioid use disorders in adolescents is even harder to come by than that for adults. There was actually one study I did not include. Some of you may have seen it, that was published in the Journal of American Medical Association just a few months ago, that came out, that looked at inpatient kind of rehab facilities targeting adolescents with opioid use disorders. And they found that I think less than 1 in 8, right? So that's just over 10% actually provided treatment with our medications for opioid use disorders. So should give us pause. And you can see that this slide sort of summarizes a lot of it, that if you look at youth overall, about a quarter of youth over the age of 16 with opioid use disorder are prescribed MOUD, medications for opioid use disorder. And if you look at that 16 to 17 age group, it's less than 10%, right? And again, those concerning disparities. Medications are more likely to be given to white males. White males statistically are the most likely to get access to medications for opioid use disorder than any other demographic. Less medication is provided for females, Blacks, and Hispanic identified individuals. And so adolescents are significantly less likely to access these life-saving treatments. In fact, the American Academy of Pediatrics, AAP, has consistently put out this messaging that we need to improve access and equitable access to medications for opioid use disorders. but we have a long way to go. And this other study pointed that out as well, that it was a large Medicaid database showing that 76% of adolescents with a diagnosis of opioid use disorder um, received any treatment within 3 months of diagnosis. So that's pretty good. But only less than 5% of adolescents who received treatment were prescribed buprenorphine, naltrexone, or methadone. So in other words, less than 5% of adolescents who were diagnosed with opioid use disorder actually received their medications for opioid use disorder within a 3-month period. So especially as we're talking in the field about timely initiation of MOUD, emergency department initiated MOUD, right? Low barrier MOUD. This is clearly something, once again, that should give us pause and is cause for concern. Again, I think adolescents, when you look at the data, which is what the next slides are going into, are similar to adults in that we know that medications for opioid use disorder help, and we really need to be giving them timely treatment. So where is that data, right? Where does that data come from? That's what we're going to go into here. So this was a classic study done back in 2008, and UNM was one of the sites for this, actually. This was a multi-site trial, and a couple of my mentors, Dr. Pat Abbott, who is now retired, as well as Michael Bogenschutz, were both involved in this study, where they looked at, again, it was a big opioid use disorder buprenorphine study, multi-site trial sponsored by the National Institute on Drug Abuse. But part of that group that received the intervention was adolescents, right? 26 participants were younger than 18 years. So they actually parsed out and looked at the outcomes for those 26 individuals. Detox versus maintenance treatment over about a 2 to 3 month period. And what this study found was that in adolescents, just like in adults, right, the maintenance treatment over that period was significantly associated with less use of illicit opioids and improved treatment retentions, two very important parameters that we look at. So again, in adolescents, keeping them on buprenorphine, maintaining on buprenorphine, led to these adolescents using less illicit opioids, and they were more likely to stay in treatment. So what are some barriers, right? What are the barriers to treatment? And I've kind of listed some, and these are just sort of from things that I could come up with thinking about it: social family stigma, confidentiality concerns, and legal concerns that I go into in the next couple of slides. Medical evidence, safety trials. There is less data. FDA approval, DEA regulations, cost, insurance coverage, I think all play into this. So what do the New Mexico regulations state? And I know there is at least a couple of people on who are not from New Mexico, so I would encourage you to look at your own state statutes as well, because that can differ. This is what the New Mexico statute says, because this is a question that comes up a lot. So what New Mexico says is that, children under the age of 14 require parental consent for treatment. This is for buprenorphine. So if you're going to start buprenorphine on anyone under the age of 14, parental consent is needed. If you're going to, over 18, of course, they can give consent. So that 14 to 18 age group, that intermediate period, they actually can provide consent for behavioral health treatments, including psychotropic medications and substance use treatment. So over 14, they can consent. They don't need parent or guardian consent, but parents or guardians must be notified. That's what it says, right? So it's a notification law in New Mexico, not a consent law. There's this is federal regulations that says in federally assisted programs, which is really anyone who, obtains like Medicare or Medicaid coverage or whatever, for example, it says disclosure to parents may occur only if minor lacks capacity for rational choice due to extreme youth, physical incapacity, or substantial threat to minor or another. So that sets up, I think, another layer of conflict. So I think, and that was something, right? So I think going back to what Dr. Ketchum was saying, I think that's the real challenge, that, the laws get complicated. So this is the approach we take, at least here at ASAP, is that, certainly we want to involve the parents if we can, for the reasons that were pointed out appropriately, right? That parental involvement is good. The child may need transport. They may need support from home. So we do everything we can to involve the parent or the guardian, to engage them in treatment, hopefully provide our non-stigma driven and evidence-based approach that this is something that can really help your child. We're going to work with them, right? These are the outcomes. So hopefully start to create some conflict between the stigma that a person may hold and the evidence for these modalities. So we make every effort. Usually we've found that that goes a long way. We notify the parents, and we provide education, we bring them in, and that resolves it. Occasionally, I think if that just doesn't work, if the parent says nope, I'm not okay with it, I think that's where sometimes it gets really complicated. And there have been a couple of instances where we've had to involve the legal department to see what, are we best meeting the needs of this adolescent or not, right? Given the complexity of this. So this can get quite complex. And I'll kind of stop here and we can have more discussion on that after the talk. And these are just common concerns I hear from the adolescent. I can quit on my own. I don't do that anymore. I'm not addicted. My doctor gave them to me, whatever. For the adults in the life of the child, not my kid, right? It's just a phase. They'll grow out of it. Replacing one drug from another can come up. And these are the things that we can really engage with them about, right? For both the adolescent and the adult, to hopefully counteract some of these stigmas that they hurt the brain. And for providers, who is the appropriate candidate? How does it affect my practice flow? What about multiple substances? What are the DEA requirements? How long will the patient take the medications? So coming to treatment options in our last few minutes, and then I'll stop here. So again, American Academy of Pediatrics recommends that pediatricians consider offering medications for opioid use disorder, that's that MOUD, to their adolescent patients. All FDA-approved medications, buprenorphine, naltrexone, methadone, actually lead to improved treatment retention compared to no medications in adolescents, right? This is adolescent-specific data. Just a quick summary. Longer medication duration equals improved retention and reduced illicit opioid use. Again, same as adults. We see the same outcomes, albeit with a lot less data. That's the last point, dearth of studies. We need more data. So buprenorphine is actually FDA approved for anyone over the age of 16, but the studies have actually looked at adolescents as young as 13 years of age. So good quality studies have gone a lot lower than that 16-year of age. It's often considered to be the first choice in this population, right? You got much better treatment retention in comparison to no medications for opioid use disorder, along with reductions in injection drug use and increased abstinence. And again, longer treatment equals better outcomes. I think that we need more studies, but I think to the point that Dr. Ketchum was making, I think injectable buprenorphine formulations really deserve a look in this population, because again, that can eliminate some of the very practical concerns around transportation and adherence and retention. So something to think about. This is just a little review of the buprenorphine specific studies in adolescents for anyone who's interested. Methadone is tricky. It's approved for anyone over the age of 18. If you're going to use it for someone under the age of 18, you actually have to show legally that the person has had 2 documented unsuccessful attempts at detox only, which we know doesn't work, or non-medication treatment before they can be placed on methadone maintenance programs. So this is a huge barrier to us placing adolescents on methadone maintenance treatment. And under the age of 18, unlike with buprenorphine, the law is very clear. Parental or guardian consent is required, and this is federal, right? So anywhere you are, this is required, and it must be dispensed from an opioid treatment program. But it does appear, to the data we have, does appear to improve treatment retention. And again, longer treatment equals less use of illicit opioids. These are some of the big studies that have looked at methadone. You can see going all the way back to 1973, with the most recent one being much more recently in 2018. Finally, naltrexone, there just isn't a lot of studies. These were only a couple of good quality studies that have been reviewed and that I was able to find. It's also approved for patients over the age of 18 years. It's also harder to initiate, and there is the risk of overdose upon discontinuation. It appears to be safe and feasible, but a lot more data is needed. Finally, this one nice review a couple of years ago actually looked at studies that compared buprenorphine, methadone, and naltrexone head to head. And interestingly, in both of these studies, what you find is that compared to buprenorphine and even compared to naltrexone in adolescents, just like in adults, methadone leads to significantly better treatment retention. So something to think about, but administrative barriers and access barriers are a lot higher with methadone. So that's why, again, we go back to buprenorphine often as a first-line treatment. Additionally, certainly here at ASAP, and Dr. Plum, who's on, can talk a lot more about this, we really try to incorporate psychosocial interventions when we're working with our adolescents with opioid use disorders. If you look at the studies, in all these previous slides, they all use psychosocial interventions. So when we look at adolescent literature for opioid use disorder, all the good quality studies have included psychosocial treatments along with medications, right? But on the flip side, they can also create a barrier to access. So that's the weighing that we have to do. And also to keep in mind that just like with adults, psychosocial interventions are not effective by themselves when we look at opioid use disorders. And these are some of the ones that I think about, at least. And Dr. Plum, please jump in at the end and correct me if you would add anything or subtract anything. But the ones I think about for our adolescent population, one is, of course, the adolescent CRA, the community reinforcement approach, which really focuses on maintaining abstinence by replacing influences in their lives that reinforce substance use and kind of reinforcing healthier behaviors. And it involves kind of healthier family, social, educational, vocational support system. So it starts by a needs assessment. What are the needs of the individual? What is the level of functioning? And then taking that into account to individualize the treatment plan, right? And they can focus on things like problem solving, coping, communication skills, engaging in healthy social recreational activities. Cognitive behavioral therapy has also been studied in adolescent literature quite a bit, right? Really focusing on kind of that relapse prevention, but also on identifying and anticipating problems, weighing the impacts of using versus non-using, right? Cues, high-risk situation, those chains that lead to use. So kind of classic relapse prevention skills that I know we do a whole talk on as part of this MOUD ECHO. Contingency management, that's what this CM stands for, right? Which really focuses on kind of positively reinforcing desired target behaviors, right? Which I know we also do a training on. So those are the three most studied that I wanted to just point out. So if you're able to combine those, I think that makes a lot of sense. So always remember, involving the family can be particularly important in adolescent substance abuse treatment, and anticipating and managing relapse is the other key point. So I will actually end with these last couple of slides. This was a nice recent study where they combined in adolescents extended release that Dr. Ketchum was talking about earlier, buprenorphine or naltrexone, with some additional steps like home delivery of medication. So treatment team going to the adolescent's home, giving them the injectable, but also then adding in contingency management, treatment of the significant other, and assertive outreach, meeting the needs of the teen. And that's significantly, I actually think this data is very impressive, improve treatment retention and reduce the use of illicit opioids. Again, kind of talking about these enhanced services combined with injectable medication and how that might improve outcomes in this population. And then lastly, integration, right? So there is also studies where the treatment for opioid use disorder was integrated within general pediatric care using a multidisciplinary approach, case management, social workers, right? And support by pediatric addiction medicine specialists. At least early data showed that it's a promising approach. And remember, we don't need data waivers anymore, right? So I think that, so ideally all the prescribers can really think about using this approach in our adolescents. And the last slide I have is this, right? The general environment, because adolescents have different needs. Developmentally, they're at a different stage. They're not adults. So how do we create a treatment system that's friendly to adults? And this was a nice paper, again, recent paper, that interviewed a lot of adolescent stakeholders to create this outcome, right? So kind of individualized approach to opioid use, more supportive interactions with service providers as the two guiding themes, And then specific elements, including genuine care and support. Adolescents are really tuned in. Do you really care about me, or are you just BSing me? Right? So really creating that environment where adolescents feel genuinely cared for. They don't feel judged, right? Reducing system level barriers and to accessing treatment and also to receiving ongoing care. So and lastly, I've included some resources that may be of interest, and references, and I will stop here. Thank you.